So we've created searches looking at the parameters in the CKD QI and the cardiovascular disease QI. Because the big overlap with diabetes, we've pulled in searches for diabetes, partly because there is enormous overlap in the hypertension and CKD QI project, in that we want to be screening our hypertensives for CKD. A lot of our CKDs will have raised HbA1cs and diabetes, and it makes sense to look at them together. We don't necessarily want to invite people in several times for several things. And I think one of the questions is, where do we start? Are there ways we should be recalling and monitoring these? Now, there's two things we can look at. One is just straightforward overall numbers. So this folder here is just going to be what your current numbers are. And we've split the searches into patients where their processes have been done and they are ready for a review. The reason I do that is I don't necessarily want to bring people in and tell them, hey, we should be considering Flozin, ACEs or statins for you, only to find that we haven't checked any of the processes that are important, well, in the past year at least. And so I think we need to be bringing people in for processes if they haven't had them before we get them reviewed by a clinician. I think that makes sense as well. You don't want to have a nurse or pharmacist or GP seeing somebody simply say, right, let's repeat everything and see you again afterwards. We want to avoid that inefficiency. And I like the Royal College Year of Care approach, where you might want to capture all the processes, ideally send the patient the results, and then bring them back for review. So we can split our patients into those who have had the relevant processes done in the last year. Now, for the sake of expediency, or to try and make these numbers manageable, I include patients who've had blood tests and ACR, anything where you might need to take something and for it to go away and for them to come back. So I don't mind if they're missing their weight or their smoking or even their blood pressure, although I think having blood pressure done ready is probably a wise thing, because that might affect what you want to do before you bring them back to the clinician. If somebody's missing their smoking, if somebody's missing their foot check, or if somebody's missing their weight, I'm quite happy to say, okay, they can come in for their review because we can still capture those processes, or they can self-report those processes. We're not going to have to bring them back again. And then in those that are ready for review, I look at who is eligible for ACE or Flozin. And I suspect these will be people that we might want to get a more senior clinician or somebody, or at least reviewed with someone with a pathway and competence to discuss the medications and explain to the patient, and perhaps arrange prescription, whichever way people want to organise that, be a nurse, pharmacist, GP. If we're dealing with large numbers, there are some of these we might be able to manage remotely or over the phone. I guess it's not, everyone will vary, but if you're needing a foot check, then you're going to have to be brought in regardless. This group will have had their blood tests, their ACR, their foot checks, if they're diabetic, which most of them are. Then realistically, we might well decide we're going to manage those slightly differently, or you might get at least know you can bring them in for a slightly shorter or more focused consultation. I have my diabetics that have had all the processes that would mean that they could be reviewed with results to hand, but they're not necessarily needing ACEs or Flozins. I've left statin out. These could be plus or minus statin as well. I think, most people, we've got a fairly standard approach to managing and offering the statins, and it's to try and simplify what can be a quite complicated search at the moment. And again, we're looking for those that still need a foot check, and those where they might be eligible for a more focused consultation. It's interesting because we're finding that quite a lot get what looks like a diabetic review, but it's not a diabetic annual review, and that's to do where if you're double clicking on the problem in EMIS, it can give you a little thing that's saying diabetes and in brackets review brackets, but that's not getting picked up in our in the old QAF rule set. So I'm picking up the people here who may well have had, for all intents and purposes, an annual review, and you might want to review that manually and decide if they do need reviewing or not, or whether they actually have had a clinician look at them and their management's appropriate. And then we have a subset of patients with either CKD or diabetes or hypertension where they're not in any of these searches, but we should be considering a statin for them. So they've had their blood test, they'll have had their lipids done, they are eligible for a statin, and that needs a review or considering for them. There's also the search for those who have possibly already had their reviews in secondary care. It may be sensible to look at these ones first and then tick the boxes if they've had a review and then rerun the search to see if they pull them out. So these are our total patients who we could bring in for review with a clinician now with a view to prescribing because their processes are up to date and we're not just sending them away to redo them again. The other search then, which is going to be bigger numbers, is looking at our various groups who have an outstanding process. So again, slightly busy, but I'll go through them because generally it's the diabetics and CKD who we are wanting to bring in for a missing process, and I've combined the two, so it's diabetics and or CKD, and I have 176 who need blood tests, blood pressure or ACR. Now, what you can see is that we've also split them into those needing blood tests and ACR, and I think we're likely to need to bring those in for those processes. Some, their blood tests are done. We could consider sending them, some of the in the post-urinary ACR testing or asking for samples. And some where they've had their blood tests and ACR and need blood pressure, they may be able to self-report or use reception-based machines. Again, we're trying to look at ways that we could streamline patients and patient numbers. These are the group that may also be eligible for flows in, but we do want their up-to-date parameters. I think I don't want to see somebody and say, well, I would prescribe this, but I just want to test you again before I do it. It's wasting my time and it'd be wasting my nurse and pharmacist time. Same for the diabetics and CKD who don't necessarily look like they are directly eligible for flows-ins. And they're the ones, again, this group, we might find that they are eligible. So they may not have had an ACR and it may be more raised than we realised, or their HbA1c may not be to target. And I think, so this group is, there may be people in here that would be eligible, but their processes are not up to date. Group 1 is likely to be eligible from the tests they've had in the past, but we just want to repeat them. Group 2, less likely, but they haven't been tested and not up to date. Again, they're split into it. There's 300 here that would need blood tests and an ACR. 86, where we might get away with just sending them an ACR kit, because I think blood pressure, again, some people will self-report. You might use your chemist to do your blood tests, your blood pressure, or you might have a machine in the waiting room. I guess there are a variety of ways of managing that, but it's useful to know if they've had everything else done. Now, the bigger group, and this comes under the cardiovascular disease QI, but also slightly under the CKD QI, is screening our hypertensives and looking for hypertensives who may have CKD, may have diabetes or pre-diabetes, may have raised cholesterols and high Q risks. And this is the group where I think we're likely to find a lot of people that have a backlog. What's slightly unfortunate about the groups above is sometimes people have had some processes but not all, which can be quite frustrating, I guess. But then it's a problem sometimes with making sure people get the processes done when they come through the door. That's part of where the prompts and templates can be useful for that, particularly perhaps the wider template, the HCA template that we also produce that pulls in everything in the one place. And again, this group, quite a large number of these just need the ACR. So this is where we might want to look at other ways of screening for ACR. If we're bringing people in for blood tests or arranging blood tests, it doesn't seem such a hardship to say bring a urine sample with you and we're also doing ACR. The issue with these searches is the numbers, really. You're looking here. I cannot cope with inviting 1,200 people in at once. It's large. And it's how do we break that down? How do we try and pull it into a system of working? So QI for me is around changing our systems and our ways of working so that we are inviting these people in, and there's a structure to bring them in, and we know that when they've been invited they're going to be getting the tests they should have, and that when they see the clinicians they're going to be offered perhaps the treatments and the therapies and the targets and optimized in a way that will really start to make a big difference to our population. And the question then is perhaps how do we break these numbers down into more manageable day-to-day numbers? And that's where the idea of inviting people in their month of birth has been popular. And we do the same thing. So it's the same search where we're looking for patients who need processes and patients who are ready for a clinician to review. But this time around, we're also going to break people up by month of birth. And the other difference here is some people we might be inviting the month of their birth. Other people, you want them to be brought in the month of birth for all their processes, and then you actually want them followed up with a clinician afterwards. And I'll show perhaps for the proposal we have for this. So if we were looking at July, we'd have patients born in July, and these are the same searches again. So these are patients born in July, either diabetic or CKD, needing blood tests, blood pressure, ACR. So again, I can see that I've got 30 in that group that we might want to bring in for blood tests and ACR, which is a lot more palatable than 360, and 7 of them who just need an ACR done. Again, this hypertensive group, which is the bigger group that we perhaps haven't been targeting as diligently over time, it's a bit more of a palatable number. We need to bring in 40 of them if we want to do the screening, and 20 of them just need an ACR sent. And immediately it means that we're breaking this down into more manageable numbers each month. Now, there are certain people that we might not want to call by month of birth. So in the QI paperwork, or at least some of it, I think I've slightly adjusted. We've got some of our CKD patients who need more frequent monitoring, and that's either 3 or 6 monthly. So this is where we would have a system to say these patients need slightly more frequent monitoring. We also have diabetics who've had their blood tests done. I don't think we're quite as good at chasing the ones who aren't to target. So I think ideally, if you've had a raised HbA1c, we should be trying to follow those up 3 or 4 months afterwards. So hopefully a raised HbA1c means something's doing something about it, and we're going to follow them up. And I split those into very poorly controlled, so higher than 69, and I've got a discouraging number of those. And I've also got the ones that are poorly controlled, which is between 58 and 68. 69 is the cutoff, and this, from a planned care point of view, patients who are waiting for surgery, it is very rare that we would want to consider elective surgery with anyone with an HbA1c of over 69 because of the incredibly high risk and rate of complications. It becomes unethical to consider something that isn't life-saving if you know the complication risk is excessively high. And I wonder whether, I think our data compares on an average basis with most places. Some places will have better control of the population than others, but I think we do need a system to make sure we're chasing those not to target. And we've got a similar monthly search for those whose blood pressure is raised. their processes are up to date, so they don't need to be brought in for blood tests or ACR, but it's been 3 months since they raised blood pressure. Do we want to check them again? We feel that quite a lot of people slip the net, and we want to try and make sure we're catching them. And again, the search is for people born in July who may actually have had some of their investigations done in secondary care. So you could check GPTR and look to see if there are results for them there that might mean you don't have to call them in again. So these are patients born in July, or they are patients who need more frequent monitoring, so there's a way of making sure that we somehow are calling these patients in, or they're very poorly controlled or poorly controlled diabetics, so the blood pressure is not the target. These numbers are relatively big, and I think there may be an issue for places to consider how much capacity they have and how much support we're getting as general practice to manage this. I know we do not get enough support for phlebotomy costs. I know that there's a big unmet need, that we've got a growing morbidity in our population. The numbers need to go up, the frequency needs to go up, and we're not getting supported with that. So I think I would look to see, can we get support somehow for this if we really want to do these things meaningfully and try and capture the population that we should. The other group I'd then consider this month is the patients born in June whose processes are up to date. Now, in this example, you'll see these numbers are low. But if these patients in June, so patients born in June, if these 30 patients had been invited in and had all their processes done in June, in July, they might well be ready. There might be higher numbers here where we could be considering a review for ACE or Flozin, but would have all their processes done ready. And again, split into those still needing foot checks, and again, split into those who aren't eligible for ACE, Flozin, but might need annual review. And it may be worth just checking because they may well have had a review. Quite a lot of practices are not coding their reviews the way we used to under QOF. And then the goal would be a rolling system where every month you invite people born that month for their processes, people who do their 3 or 6 monthly reviews, keep chasing the diabetics who are more than 3 months since a raised test, and keep checking the blood pressures of those that raised it's been more than 3 months since their raised test. If at any point somebody codes a patient with the code 9H, which is the exemption codes, these searches are designed to stop pulling those patients in for a year. So if you exempt somebody, it'll stop calling them in. So if you've got somebody who you really don't think needs calling in for blood pressure checks or for regular blood tests, then exempt them with a 9H code and they wouldn't come up in these searches. So there's the folder that tells you where you are at the moment. That's slightly different to the audits, which tell you how well you're doing. So the audits here will tell you how many of your patients who are eligible for a Flozin have had a Flozin. The catch-up numbers tell you how many of the rest are there available to consider reviewing and chasing. I do have an audit search that will give you your recall numbers. The reason I've done this is that if collaboratives or clusters or areas are thinking of projects using support from outside, from the health board or even sponsored support, this would give you an idea of the numbers of patients that you might need from each practice. So you can export this and get an idea of the numbers where you're at. So this will be your patients who are ready for a review now, 112, patients who maybe aren't ACE or Flozin eligible, but they may well need a statin and an annual review. And then patients who are cardiovascular disease, not in the above searches, process up to date, where we should be considering a statin. So these groups 1, 2, 3, we could sit those in front of pharmacists now, and their processes have been done in the last year, or you can sit them in front of a nurse or a GP, whatever method people want to use. Then there's the numbers for those patients who probably are also eligible for Flozin, but they just haven't had their processes done recent. And I think you'd end up having to just get them done and call them back. Those who are less likely to be eligible for Flozin, but are just needing some sort of process, and this is your CKDs and your diabetics. And then we've got the hypertension register. Again, these are the bigger numbers. So whether you might choose to focus on clinicians reviewing these groups now and chasing these 500, or choosing sections of it, or you might choose to do a few months at a time. You might decide to do the January and June babies as a way of catch up. But this is so that you've got a headline idea of the data in your practice. It's easily exported into a CSV file in Excel and can be shared so that you could try and get an idea of numbers if you were looking at slightly wider projects.